Thank you very much for that very warm welcome. I'm not sure about humble. Would have to ask my husband what he thought about that one. So before we get started, am I allowed to just be down here, or do I have to go up to the podium? Okay, because I would feel like the minister or something preaching down upon the congregation. The clicker, though, I think is somewhere up here. So we'll just mosey on. So people who are here in the room, are you all volunteers? No? No? What? Some volunteers. Who are the other people? Family members? Just random people who came in off the street because you heard there was free food? UNB Nursing? All right. Are you excited? It's 9 a.m. on a Saturday morning. As I was getting ready, I said to my husband, "Why did I agree to this?" And he said, "'Cause it's your job." I'm like, "No." But really, it's because palliative care is my passion, and so I am happy to share that with everybody here today. And so they asked me to speak about what is palliative care and why is it that I do what I do. So what do you guys think palliative care is? You didn't know it was going to be a pop quiz, did you? I know, but I'm really good at active and empathetic communication, and I'm really good at waiting people out. Death with dignity, okay. Caring when there is no cure. Quality of life. All right, let's get one more. We can do it. We can top 3. Caring for someone at the end of their life's journey. So yeah, you would all be correct. And there is I think a misconception that persists in society that palliative care is only for the end of life. And I hope that by the time I'm done speaking today, you'll understand that palliative care is for anyone with a life-limiting illness. So here's your history lesson, and now you have to read the fine print. So palliative care started a long time ago, actually. Back in the 4th century, that's when the first hospices were recorded in Europe. And then in the 1960s is when Dame Cicely Saunders, and she's like the famous, I was going to say like godmother of palliative care. That sounds kind of ominous though. She's the one who really started the palliative care movement over in Great Britain. And she started the very first hospice house there. And then in 1974, that's when palliative care started here in Canada. And there's a big dispute between Montreal and between Winnipeg over who actually started palliative care first. Because they're right about the same time that they both started their own palliative care unit in their respective hospitals. And so that's when palliative care was born here in Canada. And Balfour Mount, he is the one who worked in Montreal, and he's kind of I'd say the leader of palliative care in Canada. So what is palliative care? So ASCO is the American Society for Oncology Clinicians, and they say palliative care means patient and family-centered care. That often gets missed in our medical system. It's patient and family-centered. That optimizes quality of life by anticipating, preventing, and treating suffering. Palliative care throughout the continuum of illness involves addressing physical, intellectual, emotional, social, and spiritual needs, and to facilitate patient autonomy, access to information, and choice. That's a lot of very big words. But really what that means is putting the patient first, and acknowledging that their needs are not just physical, and that there's suffering that happens, and we need to address all aspects of that suffering. The WHO, I think everyone knows what the WHO is by now after the last 2 years. So they say it's an approach that improves the quality of life of people and their families facing the problem associated with life-threatening illness. So not terminal illness, life-threatening illness. And then Palliative Care Australia says care provided for people of all ages who have a life-limiting illness. And the European Society of Medical Oncology says when cure is not possible. So again, a lot of people believe that palliative care is really just for that end of lifetime, but it's not. It's for as soon as someone is diagnosed with any kind of life-limiting illness, that's when palliative care starts. Because we know that cure is not possible, but our job is throughout this illness trajectory to help improve pain and symptom management, but also to help improve the spiritual lives, the psychosocial problems that may come about, and help improve the overall quality of life. So it can be provided alongside treatments to control the disease. So yes, someone can have chemotherapy and still be getting palliative care. Yes, someone can have dialysis and still be receiving palliative care. Aims to improve or maintain quality of life. Focuses on meeting a patient's full range of needs, so that physical, psychosocial, and spiritual that I mentioned earlier. It's for cancer, but also non-cancer. A lot of people think of palliative care only for cancer patients, but we see a wide realm of patients. We see patients with end-stage heart disease, end-stage lung disease, end-stage kidney disease, neurological diseases, ALS, really any kind of illness that's not curable. And it's for all ages, so there is pediatric palliative care. And it's best provided by an interdisciplinary team. Now, I just want to highlight that for a moment, because I'm not that humble, actually. I like to take credit for everything. But it's the whole team that makes a difference. And one person cannot provide palliative care alone. We depend on the nurses. We depend on the social workers. We depend on psychologists. We depend on our spiritual care manager. We depend on our volunteers. I cannot wait till the volunteers can come back into the hospital. Please. Right, I'm in a spiritual house, right? So I could actually do a prayer. Volunteers provide so much care to our patients and families and offer so much comfort. They're a very important part. But you can't do palliative care with just one member of the team, because each team member brings something different to each encounter with each patient. And it might be that the social worker, is helping with children or grandchildren and helping to prepare them for grief. Or it might be that the doctor's working on the nausea medicine. It might be that the nurse is helping to get, people in from out of town into the hospital because of lovely rules that we have. So it's a whole team approach. Pop quiz. You didn't know this was going to happen at 9 o'clock on a Saturday morning. So which of these people might benefit from a palliative approach to care? So I'll let you read those for a second. So Mrs. Mary T, she is 66, and she has pancreatic cancer. That's unfortunately now spread to the liver. She's very thin. She doesn't want to eat anything, and that drives her family crazy because they keep trying to get her to eat. They don't understand that she can't eat because the cancer's taken away her appetite. And there is disease progression despite having chemotherapy. So do you think that she would benefit from palliative care? A couple of quiet nods, a couple of yeses. Be confident. Yes, you are correct. Mr. Paul L. He is 53 years old. He's been diagnosed with lung cancer, but the lung cancer has spread. So if the lung cancer has spread, that means that it's no longer curable. There can be perhaps some treatments, but it's not a curable disease anymore. He is waiting to see the oncologist. Would he benefit from palliative care? Oh, I got some yeses on this side of the room. Yes. Oh, you were listening. Good job. So far, 2 out of 2. So yeah, even though, even in the picture he looks fairly well, he is someone who would benefit from that palliative approach to care. And so that palliative approach to care is looking at that whole physical, psychosocial, spiritual approach to care. And yes, we can't cure his cancer. He may live for many years. He may live for a couple of years. We don't know which way things are going at this point because it's just an early diagnosis. However, for however long he is with us, we can help with that illness trajectory. We can help with him on his path and help make sure that the time he does have left is the best possible time. All right, Mr. Morris C. He is 73 years old. He has advanced COPD, so chronic obstructive pulmonary disease. A lot of people don't realize that is a terminal illness. That is not a curable illness. We cannot cure COPD. We have medications that can try and help control them, but at some point in time, the lung tissue is destroyed to the point where shortness of breath on mild exertion. So what does that even mean? So that means that he's sitting in his chair in the morning, and to get up to go to the bathroom, he's short of breath. Sitting on the toilet, he has to sit there for a few minutes and catch his breath. Then he has to get back to the living room, and he has to sit there for 10 minutes and catch his breath. So that's what that means. So is he someone who would benefit from a palliative approach to care? Oh, we're getting more confident now. I like it. I like it. All right, let's say, so 1, 2, 3. Would all these people benefit from a palliative approach to care? Oh, see, I can make up a crowd. I can do it. I can make it work.
What comes to your mind when you hear or see the word palliative? Many people, appropriately, think of words such as compassion, dignity, or quality of life. However, for many people, what comes immediately to mind are the words dying, terminal, and end of life. Unfortunately, too few people think of palliative care alongside treatments to control the disease.
I'm Dr. Gordon Giddings. I'm a palliative physician at the University of Ottawa and clinical content editor of Pallium Canada. The aim of this Pallium Doodle is to explain that palliative care is not something for just the last days or weeks of life, but should be initiated much earlier.
To better understand this, let's look at the illness trajectory, starting at the time of diagnosis of a life-threatening illness. In some cases, the disease, whether it be cancer or another non-cancer disease, can be cured with treatments. In other cases, however, the disease may be incurable. Let's draw a graph around this journey. On the x-axis is the length of that journey from diagnosis to death. On the y-axis is the goals of care, the treatment and care options in focus. Now, unfortunately, because people often think of palliative care only for the last days or weeks of life, they will only activate a palliative care approach in the last days or weeks of life. Let's look at the negative consequences of this. They include lack of symptom control with unnecessary suffering, inappropriate treatment choices, prolonged psychological distress because no one is addressing the fears and concerns of the patient, lack of discussions about prognosis, or lack of preparation regarding care choices and treatment goals. So what do we need to do? Well, we need to erase the old model of palliative care and use a different model, a different approach. What if we start palliating early in the illness? This does not mean that treatments to control or cure the disease and palliation and supportive care are mutually exclusive. The model of early palliative care is much more patient-centered and responsive to patient needs. Is there evidence to show that early palliative care is better than late palliative care? In a large U.S.-based study by
You
Kimmel
can stop
and
it. We don't need to
colleagues,
listen to the
the
evidence.
model of early palliative care.
You can just believe me. So we use the model at the bottom when we talk about palliative care. And that's when we're really right at the beginning. Probably don't need us that much, but it's good to have the conversation about what does this mean? What does it mean to you and your loved ones that you now have this diagnosis? What does it mean to your job? What does it mean to your finances? What does it mean to your future time that you have with your loved ones? And then as the disease progresses, having more pain, having more problems with nausea, starting to have anticipatory grief, thinking about dying, needing some more of those psychological supports. And then we get to our end-of-life care. And that's when we're actually focusing on the main part of how do we care for end-of-life. And for end-of-life, we're looking at making sure that the pain and the breathing is controlled, making sure that the terminal secretions that happen, make sure that those are as controlled as possible and the family understands what that means. Making sure that restlessness and agitation is under control. That's the end-of-life phase. But look at all that time before we get to that end-of-life phase. That's when I feel like we make the most difference in a patient's life. Something that I found a lot, and I see a lot, is people don't talk about what to expect as the disease progresses. And so then I find that time gets stolen from patients and their families because they don't understand that perhaps there's only 3 or so months left and they're spending that time maybe trying to continue on with treatment, and maybe they would have rather spent that time in the garden or rather spent that time taking that last trip or rather spent that time with the newborn baby. And so it's really important, I think, honesty. And I think that's something that palliative care helps to bring to the table, is having those discussions and talking about advanced care plans, what's important to people, what would they like to have happen to them, going back to that family-centered plan. So what does palliative care in Moncton look like? I'm so excited I got to add hospice to this slide. So palliative care in Moncton, so home. So we see lots of people at home. With the help of extramural, without them we could do nothing. So extramural is integral in providing palliative care in the home. And so we see people at home and we provide the care that they need at home. There's personal support workers that come in to help as well. And there's home volunteers, and I understand that program is getting back up on the road now that we're living with COVID. Yeah, it's not going away. Don't listen to those people, it's not going away. No laughs about that, no? So home, and then we have the hospital. So hospital, right now, we have a palliative care unit at the Moncton Hospital. Unfortunately, with the staffing shortages, the Georges Dumont Hospital has had to close their palliative care unit. So that is a huge loss to them, and the nurses have been redeployed. Huge loss for palliative care for that hospital. We currently still have our unit at the Moncton Hospital. We also see patients throughout the hospital, whether they be in oncology or orthopedics or whatever, and we provide palliative care services to them there. Our palliative care unit is for patients who have symptoms that aren't controlled or for patients who are in that active end-of-life phase. And we sometimes, before we had the residential hospice, we would have to use our palliative care beds as a hospice bed. So what is a hospice bed? So a hospice bed is for patients who need the expertise in nursing for pain and symptom management, but their symptoms are relatively controlled. And they're in their last weeks to up to 3 months of life. And so that's someone who would go into the residential hospice. And before we had a residential hospice, we only have a 7-bed unit, and so some of our beds would be used, usually about 3 of them, as hospice beds, which meant that we didn't have beds available for patients who had symptoms uncontrolled to be able to bring them in from the community. We often had to wait many days for that. Or for patients who were actively dying in the hospital, oftentimes they would end up dying in like a 4-bed ward or even in a semi-unit. And so now that we have the residential hospice, those patients who are in their last days to weeks up to 3 months of life now are better served at the residential hospice. Have you guys all been to Albert House? It's beautiful. It's a great facility, and it's amazing what they've been able to do in the short amount of time, really, that they have been open. And taking that piece, so the residential hospice takes patients from the community as well as taking patients from both hospitals. And so they're able to provide that care that they need, that expert care, in the last days, weeks, up to 3 months of life. So I'm so excited and so happy that when I was doing this presentation, I got to put residential hospice on. It made me excited. So this is the second part of my presentation. So before I move on, does everyone understand what palliative care is? Okay, yeah, I'm trying to get everyone's eyeballs. Okay, good. So why do I do it? It's depressing. Why do you see patients who are dying? Oh, you must be a special person to be able to do that. I never really know what to say when people tell me that. I'm like, oh yeah, I am a special person. But why do I do it? I do it because I know I'm actually able to help. And what I was trained in is helping in, pain and symptom management. So if someone's pain isn't controlled, I'm able to fix that. If someone is vomiting uncontrollably, I'm able to fix that. If someone is having problems with their breathing, I can actually fix that. I can't fix the reason why, which is what a lot of people go into medicine for, because they want to try and, fix the actual problem. But I can fix how they're feeling. So I help with pain, nausea, constipation. I love talking about poop. I love it. It's a dinner time conversation. Did you know, even if you're not eating, you still make 1/3 a cup of poop a day? So you have to poop. It's very important. It is a huge quality thing. It really is. We talk about sleep. We talk about mood. We talk about anxiety. We talk about, what are the hopes? Well, and people are like, hope? Like, how do they still have hope? You can still have hope even if your illness is incurable. What do you hope we are able to help you with in the time that you have left? One of the questions I ask most of the time is, what do I need to know about you in order to help you? What do I need to know about you in providing the care for you? And it's interesting sometimes what people say. This one lady said to me, you need to know I'm stubborn. I'm like, oh, I wasn't expecting that. I'm like, okay, you're stubborn. What does that mean? She's like, well, you're going to tell me what I should do, and I'm going to say no. I'm like, okay. She goes, but I know I'm going to need to do it, so you're going to need to fight back. I'm like, okay, we can fight. I can do that. So what do I need to know about you to offer the best care possible? So that's the first reason I love palliative care. The next one is working in a team. I'm actually inherently lazy. Do you believe it? Sometimes. I don't like gardening. That's not on my things of what do I want to do. You know, in my time that I have left, gardening is not one of them. So I will get my husband to do all that part. But working in a team. And I love the camaraderie that happens in the team approach. I thrive off of interacting with people. I thrive off of, well, what do you think? I don't know, what do you think? Okay, let's try and come up with a plan together. Because sometimes it's quite difficult to figure out what the best option is. I love working with the team members. I love what everyone brings to the table. I love that psychology has a completely different approach than what I have or focusing on. Spiritual care. I'm not very good at spiritual care. I'm really not. I'm not really good at explaining it either, because everyone has a spirit, and spiritual care is not just religious care. And a lot of people don't really understand that. And so I love our spiritual care manager who helps to bring that part in and helps to nurture the person's spirit. And is it that they need some quiet time? Is it that they need some time in nature? Is it that they do have a particular religious belief that they, that's very important to them? And so the spiritual care team, they're integral to what we do. Nurses, woof. I'm terrible at looking at puke, any of that stuff. Without nurses, I don't know what we would do. The nursing shortage in New Brunswick is terrible. I think it's just brought home how important nurses are to the care team. We have a clinical resource nurse who works with our team, and the clinical resource nurse helps us go to every floor that we go to, and she'll help teach the nurses that are on the other floors. Like, oh, well, actually, if you put the pillows this way, you can help them breathe better. Oh, well, hey, if you look over here, you see how they got their breakthrough dose an hour before their other dose? Well, if you did this instead, and so the nurses are also integral in helping to educate other nurses. So I love our palliative care nurses. I love our team. I don't know if I can say enough about our team. It really is important. And the volunteers. And like I said earlier, I can't wait till the volunteers can come back into the hospital, mainly to start baking the cookies again. I'm joking. The volunteers are the ones who are able to have that time to sit with the families and maybe get that extra cup of tea or just provide some support. Or maybe the family wants to go home and have a shower. Oh, well, I can sit with your loved one while you do that if you don't want them to be alone. So volunteers are really important to the team. And that's part of why I love palliative care, is having that whole team approach. Improve quality of life. So it's the little things. I had this one patient who really wanted to eat KFC. Might not have been my choice, but that's what she wanted. She wanted to be able to eat KFC again, and she vomited anytime she ate. I'm like, okay, I can fix this. It took me a while to fix it, but eventually she got to eat KFC. Wasn't a lot of KFC. She didn't get to have like the full 3-piece meal, but she was able to have some of it. And that to her was quality of life. And so with each patient, I ask, what is it for your quality of life? What is it that makes life worth living? What is it that I can do to help with? And that makes me happy, and that's what really keeps me going, is even though I'm working with people who have terminal illnesses, I'm able to do these things that helps them have a better day. I had one patient who had a bowel obstruction, and she really wanted to have McDonald's. And I'm like, okay, sure. So she was able actually to eat again, but unfortunately she ended up getting sick after she had McDonald's. But she said to me, oh, it tasted just as good on the way down as it did coming back up. I was like, oh, okay. She's like, I was just happy I was able to actually eat it. And I was like, okay, well, I think we have a little bit more work to do. But a lot of it centers around food now that I'm thinking about it, but not all the time. But food is an important part of our culture. And so if that's what's going to be the quality of life, then that's what we're going to work on. Making connections. So when I sit down and I meet with a family, and it could be that the patient themselves are comatose. They might not bring anything to the conversation, but sitting down with the family and saying, well, if your dad wasn't here right now, and it was 3 months ago, what would your dad be doing? And getting to know about that patient, and getting to know what they like to do, and often just hearing those stories. And then the family really appreciates being able to share those stories. And we never know if the person who's in that active end of life stage is listening. We never really know if they're awake. There was actually a really interesting study that was done on actively dying patients, and they looked at the brain waves, and they looked at when someone was talking and how the brain waves changed. And so we believe that they do listen and they do hear to us, to what we're saying. Though sometimes they are sleeping, so they're not going to be listening, but sometimes they will be awake. They just don't have the energy to open their eyes to tell us that they're awake. And so sitting down with families and having those stories and making that connection with them, that's what really matters to me in my job. And that's what makes palliative care worthwhile to me. And I always say when we're having these conversations, I'm like, if you've managed to keep it a secret, who broke the window when you were kids? Don't say right now, because Dad's listening. And if you don't want him to get mad, then let's not talk about that. And so just having those stories are so important. I'm just going to close in talking about a couple of stories for some patients. And these are more of the extraordinary ones that don't happen every day. So early on in my career, probably in the first couple of years, I drove down to Hillsborough for a home visit for this patient with cancer who had just got out of the hospital. And I arrived and was met by this golden retriever, this 1.5-year golden retriever, bounding with energy, whose name was Quincy. And I was like, oh, this dog's beautiful. This is great. Yay. There's a puppy. Yay. I love dogs and animals. And so I meet the patient and his daughter. And the patient is in bed. And he had just been sick. And he was having a lot of pain. And he was all swollen. And I'm like, wow, they discharged you from hospital is what I'm thinking. But he was insistent on coming home. And so his daughter looked at me and said, I'm flying him home to Ontario with me in 2 weeks. He needs to be able to sit on a plane. I'm like, oh, how am I going to get this man who is laying in bed, full of fluid, vomiting, full of pain, not eating, being able to sit in a plane to get to Ontario so that he can go live with his daughter for his last days? I was like, challenge accepted. We can do this. So I won't bore you with the details, but we were, as a team, it wasn't just me. I'll pretend to be humble. With extramural, we were able to drain the fluid from his legs. We were able to get his pain under control with a pain pump. We switched his medications around, got the vomiting under control, got him eating again. Not a lot, but some. And so it took 3 weeks, not 2 weeks. I'm not a miracle worker. And he was able to get into that plane and be able to go home with his daughter. That made me feel pretty good. Let's go back to the dog. So Quincy. So I said to the daughter, well, what are you going to do with Quincy? Like, he must be coming too. And she says, no, there's no way I can take that dog, because he was a 1.5-year golden retriever, bounding with energy, whose owner had been sick the last 3 months. So you can imagine how much exercise that poor dog was able to get. And she goes, no, the dog's going to the SPCA. I was like, oh. So I came home and I said to my husband, there's a dog, and he's going to the SPCA. And my husband said, oh, he'll be gone in a week. And I was like, and he's like, no, he's not going to be like euthanized. Like someone's going to adopt him. He's not going to be there for long. And I'm like, but he has to go to the SPCA. Like that's traumatic on the dog. So my husband and I went down. We did multiple visits to this patient, but my husband came down with me. And so then the patient interviewed my husband to see what kind of a dog owner he'd be, and how many times he'd walk him, and how big is the yard, and how many hours would he be alone. And anyways, we passed the interview. And so then Quincy came home with us. So on the day that the patient was flying home to Ontario, what we ended up doing is bringing Quincy to the airport to say goodbye to the patient. Except when I got to the airport, the Moncton airport is very strict on animals. The Halifax airport, you can bring your dog in no problem. The Moncton airport wouldn't let me bring the dog inside the airport. And so my husband had dropped me off at the door and he went to park. So I left the dog with the security guard. I just gave him the leash. Here, you hold on to the dog then. And so I ran into the airport and the patient had already gone through security because WestJet was amazing with helping to accommodate his needs. Anyways, WestJet went and got him, brought him back out, brought him outside so that he could spend some last time with his dog. And so that was also a whole team approach to make that happen. But it was an incredible experience for me to be able to get this patient well enough to go to Ontario, and then we also provided a home for his dog. So Quincy stayed with us for many, many years. Quincy passed during the pandemic when he was 13. But that was a patient who was quite special to me. So that's more of an extraordinary case. Another time, we had a lady who was from out west, Edmonton area. And she moved to the Miramichi to be with her boyfriend because they met in the oil fields and whatever. But then she was diagnosed with metastatic cancer. And it was quite bad and it spread quite fast. And so she was in our palliative care unit. And her surrogate family from the Miramichi couldn't come very often. So really, she was alone in Moncton. And we were talking to her children back in Edmonton, and they're like, we'd love for her to come back home. And I was like, there is no way she can come back home because she has bone metastasis, riddled with bone metastasis. So anytime you moved her, she would have pain. Like she needs to be in a hospital bed. So we were chatting and we looked into like life flight and things like that, and it was going to be, I can't remember, like $30,000 or something, and the family didn't have that. And so the team and I were thinking, and we're like, what if a doctor and a nurse fly out with her, and that way we can medicate her and keep her comfortable for the flight? And then like, okay, well, how would that work? Like, well, what if an ambulance and so it took a lot of work and a lot of prayer. And we were able to take this patient, and again, WestJet, I can't say enough about WestJet and what they were able to do. So we were able to get the patient on an airplane in Moncton. We had the EMS keep her on a stretcher until like the last minute. So we tied up an ambulance. This was when the ambulances weren't short supply. We tied up an ambulance who went like right out to the tarmac. Like we got her on the airplane. We had her medicated. And then when we got to the airport in Toronto, we had to change planes in Toronto. We were met by the ambulance services at the Toronto airport who put her on a stretcher again and waited until we changed planes. Again, we were able to pre-medicate her. And then we were able to get from Toronto to Edmonton, and we had the palliative care unit there, made sure an ambulance met the plane, in Edmonton. And then we were able to get her sent off, and we went with her to the palliative care unit to make sure she got in and was tucked in, and then her family came. And so then we quietly left, so the nurse and I. And then we went to the Outback that night for supper. If anyone knows what the Outback is, one of my favorites that's nowhere near Moncton. And then we took a flight home the next day. And then it was kind of done. It's like, oh, wow, like, I can't believe we just did that. But we were able to get her home, actual home with her family. And I think it was a month later she passed away. And the son called our office, and it was after hours, and left the most amazing voicemail, just thanking us for everything that we had done for his mom. And yes, in that situation, that's extraordinary. That's a little bit above what we normally do in a day's work. But those things matter. And the things we do every day matter. And mainly it's eating KFC or McDonald's or getting to the beach one last time, or being able to be awake enough to have a card game with my grandson. You know, those things matter. The extraordinary is cool, makes great stories, but the little things, the everyday things that we're able to do for our patients and our families, that's what makes me love palliative care. It makes me want to keep doing it every day. So, thank you.